Welcome, Adam. Adam is a general internist, and he's also a medical educator at Beth Israel Deaconess Medical Center and an assistant professor at Harvard Medical School. So many hats, Adam, there. He is director of AI programs for the Carl Shapiro Center for Education and Research, and he leads the task force for integration of AI into medical school curriculum. He's also an associate editor for the New England Journal of Medicine, AI, and his research focuses primarily on medical education, clinical reasoning, integration of digital technologies, and human-computer interaction, especially with AI. His first book, which I haven't read, but it sounds fascinating, so I'm going to certainly after this talk go and get a copy of that, Shortcuts Medicine. And he's the host of the American College of Physicians podcast, Bedside Rounds. So, whoa, what an illustrious set of fantastic career choices there, and amazing variety of work. We're really looking forward to hearing from you about the AI human intersection considerations for patient safety. Over to you, Adam.
Thank you, Dr. Lawton, and thank you for having me, everybody. I'm very excited to be here. I will go ahead and share, actually, I'm not going to do video sharing. I'll go ahead and share my screen. So I do want to get a single conflict of interest out of the way. I am a visiting researcher at a London company, DeepMind. So I do spend 20% of my time doing research on human-computer interaction at Google DeepMind. And I will call out the specific areas when I talk about my work where that conflict of interest is important. Okay. I have an agenda. I'm going to do this all in 40 minutes. It's a lot to do in 40 minutes, but I talk very quickly, even when I'm not that caffeinated, because I want to have plenty of time for questions and discussions. So my work very broadly focuses on human-computer interaction. I was doing this prior to LLMs. Like my original work focused on naive Bayesian risk prediction models. I never really did ML classification like expert systems. But I'm going to talk first about our sort of traditional quality and safety infrastructure and some of the work we're doing on a theoretical basis for using language models in that. And then I'm going to get into what most of my research, probably 80% of my research is in, which is thinking about new workflows for patient safety, and two categories there. And I'm going to spend less time on the first, so it's going to seem like I'm moving really quick on stuff that, pretty exciting that we're actually putting into clinical deployment, or we have put into clinical deployment. And then I'm going to spend more time talking about the sort of, I wouldn't call it less practical, but the stuff that is quite a few years off in terms of implementation. So this is how I explain to my CQO the promise of LLMs when it comes to our traditional safety infrastructure, which is that LLMs, not human, very, very clearly, they're not capable of human-like oversight, but they are capable of some degree of human-like oversight at scale. So the cell, there's one thing of talking about the promise, and the second is of actually implementing it. But the cell is, imagine that you could have another physician or a junior physician review charts, review information in roughly real time. What would you do with that? And there have been some work at other institutions, and when I say other institutions, it's largely NYU. So NYU in New York has really been a leader in this, in creating what we would call scalable oversight solutions. So you should probably invite her to one of your sessions. Verity Shea, she is my friend. She's a brilliant scholar working on this. So Verity Shea, back in the old days, so the pre-ChatGPT days, did a lot of work with BERT classifiers to build systems that could actually extract clinical reasoning from charts and then use that to identify residents. They were only using it with residents who might need more help. They did a bunch of cool experiments showing that, for example, the busier your shift got, the lower your quality of reasoning. And they also did some really cool work showing how this reasoning could predict errors, or was associated, I shouldn't say predict, could be associated with errors in certain diagnostic categories. This was a BERT model. If anybody has worked with BERT, you know many of the problems, which is that it needs to be manually trained and isn't going to have a lot of generalizability. And in fact, when they first deployed the same system at the University of Cincinnati. It didn't work very well. They have since used a GPT model that works much better. Now, this is more for educational use cases. NYU recently published a paper in the Journal of Hospital Medicine showing that they're able to do real scalable oversight on missed or delayed diagnosis of VTE. It uses quite primitive. This field is moving so quickly that I can point to something that seemed like science fiction in 2018 and call it primitive. But it used fairly primitive language models, but had a really um, at least for this diagnosis, a clinically meaningful ability to post hoc detect, so not prevent, but detect after the fact. And they have built a dashboard now for 10 different diagnostic categories to give people feedback, to give attending physicians feedback on delayed or missed opportunities for diagnosis. So this is in deployment right now at NYU. This is now actually grant funded work, and I expect to see a publication looking at like the effects of the dashboard in the long run. Now, I have never been that excited by like error adjudication. Like at the end of the day, it is great to pick up errors after they happen. That obviously helps our quality and safety committees and thinks about ways we can improve processes in the hospital. My interest has been more in preventing errors in the first place. And e-triggers, which everybody knows e-triggers, have been obviously of quite interest. And there are some exciting traditional e-triggers. Hardeep Singh recently had a piece in JAMA IM that looked at the efficacy of e-triggers in the emergency room. So this is a study that's going to be coming out very soon in JAMA Network Open. And we're currently running a randomized controlled trial across our network. So we basically took Hardeep's e-trigger protocol and asked a very simple question. What if the e-trigger sequentially led to a language model? So you use the e-trigger initially as the first screen, then you use a language model as a second screen. And then we studied it in all the high-risk emergency conditions that Hardeep did. And this is a retrospective study. We're studying it prospectively now. And what we found is that for most of the conditions, not all, it was great. We got a very high or a very high negative predictive value, which is what you want in an e-trigger. So we sequentially studied this like a rules-based e-trigger followed by an LLM screen. One of the really interesting things is initially we were very influenced by the diagnostic safety movement, and we actually used SaferDX as our initial screen. It turns out that prospectively, SaferDX didn't work at all. SaferDX was no better than flipping a coin, and effectively we had our emergency room doctors, like a panel of emergency room doctors, just work on random prompts to detect errors. And in the end of the day, it was kind of vibes, like LLM vibes that helped create that second screen. But we got appropriately high negative predictive values, and we are now studying this in a randomized on a per emergency room basis across our network to detect patients at high risk of errors. Yeah, this is the data here. So it didn't work in every single condition, but generally optimistic. And again, if you have a high NPV, positive predictive value probably does. I shouldn't say it doesn't matter that much, but as long as you have a sufficiently high NPV, all you're doing is improving the ability to pick up errors. Okay. And this gets us to, at least in the United States, where a lot of the discourse is right now on safety, which is precision education. Again, the leader in this is NYU and then the University of Cincinnati. The idea of precision education is that we can use, and this all predates LLMs, right? This work has been going on since the late 2010s. But the idea that we can use big clinical data, so within the EHR, to get personalized feedback, to look for potential deficiencies, to look for missed opportunities for diagnosis, then give targeted interventions to those clinicians, and then track the outcomes. This is effectively what NYU is doing with their pulmonary embolism detection work. They're trying to detect people, like whatever cohort of physicians has a higher rate of delayed VTE, and then give them personalized education, and then hope that they'll be able to see. So this is a model that the American Medical Association is really pushing. The medical boards are very interested in using this sort of personalized like feedback to improve quality of care for what is called maintenance of certification. So it's hard to operationalize because of privacy laws in the US, and our EHR vendors have never particularly been interested in education. But this is just so everybody knows, this is really where a lot of the energy is focused right now. And with that, I want to get to the really that. So that was my overview of our work on what I would consider the not like important, but not as exciting stuff. And now I want to talk about the very exciting stuff. So I consider myself what I would say big AI in that I'm not prescriptive about what artificial intelligence is, and I and recognize that doctors have been working with AI technologies of vastly different types for well over a half century. I always like to pull up this quote from Bernard Shaw just to show how old these ideas are, right? So Bernard Shaw, if you will notice the date on this, he is writing in 1918, reflecting on how people used to use spreadsheets. And obviously, a spreadsheet was literally you would do math in both directions for bookkeeping and now use counting machines. And then says in the clinics and hospitals in the near future, we may quite reasonably expect that the doctors will delegate all the preliminary work of diagnosis to machine operators as they now leave the taking of a temperature to a nurse and with much greater confidence in the accuracy of the report than they could place in the guesses of a member of the Royal College. The observation of the symptoms is extremely fallible, depending not only on the personal condition of the doctor, who has possibly been dragged to his case by his night bell after an exhausting day. I have a lot of sympathy for that. My pager went off last night. Thankfully, didn't wake my wife. But upon the replies of the patient to questions which are not always properly understood and for lack of the necessary verbal skill could not be properly answered if they were. From such sources of error, machinery is free. So this has been I don't want to call it a dream, but this has been a guiding star for the field of medicine long before electronic computers existed, only taking off with electronic computers. And I do want to say, if we were just in, like, if you had asked me 2.5, 3 years ago, Adam, what is going to happen with language models? I would not say that we were getting to this point. I would say, okay, well, these are cool technology. They do NLP, natural language processing, far better than any other sort of algorithm. But like, it's going to be decades of figuring out how this happens. So I do want to reflect that there have been real technological improvements in the last 18 months that have changed the way that I personally think about this technology. And that is effectively, those are reasoning models or reasoners. Some people call them large reasoning models. The word LLM has become so non-specific because they're all like these Frankenstein algorithms. And obviously it's proprietary, so nobody really knows what's in any of them. If you will recall the early days of language models, we had lots of tricky ways of prompting them to improve their output. Take a deep breath. If anyone remembers the take a deep breath era, there was a pretty good paper that if you instruct a language model to take a deep breath, it will solve math problems better. When I reviewed, I shouldn't say this, but I was one of the peer reviewers for the pulmonary embolism paper. And obviously I wanted to see all the prompts. So I was like, can you send me all the prompts? And every single prompt had take a deep breath before solving, because that was sort of the state of the art in improving performance. Not very scientific. Language models are super weird. The best way that we knew to improve language model performance, and I actually have, well, the grant has shifted. This is just, it's hard to like do grant funded research when this field shifts so much, is something called chain of thought. And chain of thought is a prompting strategy where you instruct a base language model to solve a problem like a human. So to give an example from the Undiagnosed Disease Network, this was a great paper that's like early 2024. If you tell a language model basically to give me a differential for this very complicated UDN case, it doesn't do a very good job. The chance that, I mean, the undiagnosed disease network cases are obscenely difficult. Or some of them don't have diagnoses by our modern nosology, but you would get something like 15% accuracy, I believe was the number. Then if you told it to first write a differential, second, go back through the case, tell me everything that fits, everything that doesn't fit, and finally at the end write a differential, the accuracy would double. It would go up to about 30%. And that's effectively chain of thought. Computationally, we can talk about why that happens. It's quite interesting, and I could blabber on for a while about it. A lot of LLM stuff ends up sort of like hand wavy anyway. Anyway, what the labs ended up doing, OpenAI was the first lab to do this. They realized that they could have a new paradigm of LLMs where they do the supervised learning for accuracy rather than just for reinforcement learning, but from human feedback. So effectively, they let it think out loud as long as it wanted. They did pre-training to make it structure its thoughts like humans, and then they rewarded the model on whether it was right or not. So for example, in the diagnostic process, you reward it on whether it gets a diagnosis or not. You can do this with math, with science. And then, of course, what has happened with this technique is that the models improvements, they're capable of doing things like this reasoning architecture is capable of doing things that freak me out, and that a next token predictor, right, effectively a fancy autocomplete or multi-dimensional autocomplete should not be able to do. And we are still on the upswing of this technology. The recently we've had some breakthroughs in architecture that allow them to complete real agentic tasks. We've been talking about AI agents for a while. I mean, again, the word AI agent we were talking about in the 2010s, it predates talks about language models. Um, we finally, I would say, have agents that are capable of fitting what I would consider a definition of an agent, which is an AI system that works in, sort of a cybernetic loop that is able to do tasks on its own before reporting back. I don't know if anyone has actually used, if we can talk after, if anyone has used Claude Code or Claude Cowork here, you know what I'm talking about. It is, from my experience, like I'll tell you, Google DeepMind, my Google colleagues no longer write code. Maybe 10% of the time they write code. Most of their time they are directing swarms of agents to complete work in a way that is like really disorienting from someone who's been working with them for the last 3 to 4 years to see like the way that this technology has changed how they work. Okay, so that is sort of the technological backend to explain this new era. And I'm going to go over some of the evidence and then talk about the implications in clinical care. And this is, again, this is what Bernard Shaw was talking about over 100 years ago, which is, are LLMs capable? Can they perform second opinions? Could you have a doctor or a patient talk to an LLM and give you the answer? So old evaluations, old machine learning evaluations for language models, which is multiple choice tests, usually taken from board exams. Not particularly interesting. They're fully saturated right now. Back in the 1950s, Robert Ledley and Lee Lusted published a very famous paper on in Science, the reasoning fundamentals of medical diagnosis, where they basically laid out. It's a wonderful paper. Actually, it's a very difficult to read paper, but it's historically very interesting because it's considered sort of the grandfather paper of the clinical reasoning field as well as medical artificial intelligence. And they lay out a challenge on how you would know that a system is capable of thinking like a doctor, and that is solving the New England Journal CPCs. And historically, every single AI breakthrough has tested itself on the CPCs. One of my favorite is in the 1980s Internist 1. I think it's 1982 was published in the New England Journal. It actually can solve at a parity with humans. So not that this is some impossible task. We've been able to do it with expert systems for a while, but it's this sort of classic exam. And unsurprisingly, language models are now capable of solving sort of any complex case, not only at a superhuman rate, but effectively perfectly. If it's written to have an answer, a language model will get it. Not surprisingly. LLMs can also display their reasoning. This is where we're getting closer to the second opinion territory. Can they, in a reasonable manner, explain their reasoning? The answer is yes, superhuman, in fact. And superhuman, literally just meaning if you look at the average of attendings, the AI model, as blindly adjudicated, the AI model is better. And then if you want, I can show a video of this. Me and my colleagues at Harvard Medical School in the bioinformatics department decided to train an AI model. Not train, we built a scaffold. And I can, again, technologically go over what we did, but we made an AI model that is trained to be a CPC discussant. You can talk to it. It can give a live presentation. Its name is Dr. Cabot, named after Richard Cabot, who founded the CPCs over 100 years ago. She's quite funny. She like cracks jokes. She can discuss cases. This was covered in the New Yorker, and actually about 4 months ago, the first ever CPC solved by an AI system was published in the New England Journal of Medicine by Dr. Cabot against Dr. Gurpreet Dhaliwal. This piece will be coming out in Nature Medicine. Basically, what we showed is that when you blind doctors to the outputs of real New England Journal discussants, we used unpublished cases versus Dr. Cabot. The people actually rated Dr. Cabot higher. And we have a really funny, one of our reviewers texted us and was like, guys, Dr. Cabot isn't doing very well. None of this logical reasoning makes sense. They were talking about the human output. So we've gotten to the point that they can explain their thinking really, really well. I can't go back. There we go. One of the scary things about this is that they explain their reasoning so well, but it's not necessarily correlated with whether they're right or wrong. I'm going to talk about a clinical trial, a phase 1 clinical trial I ran in a few minutes. One of the cool subgroup analyses, or I should say exploratory analyses we did, is we looked at the reasoning traces. This is for in my clinic, patients talk to an AI system before they talk to their doctor, and then the AI system talked to their doctor. One of the exploratory analyses that we did was how how confident is the model and how good is its reasoning, and then we did a segment by whether or not it was right or wrong about the diagnosis, on the idea that maybe we would be able to see some early signals if the model was going in the wrong space. And unfortunately, we found the exact same thing as psychological studies have shown of human physicians, which is the AI model's logic appears to be equally good whether or not it's right or wrong. So you could even argue that how good it is at explaining its reasoning could be negative if the model itself is wrong. Anyway, this is all fascinating robopsychology. LLMs have, I when I first saw these results, I was shocked. I shouldn't be shocked knowing how they work, but they have an emergent probabilistic reasoning that its vibes are not epidemiologic, but are nonetheless closer to reality than human clinicians. Which seems to not matter until you think about sequential diagnosis. This gets very interesting. This is a Microsoft paper, and I think the exact details of this paper matter less rather than because Microsoft wants its own system to look the best. So this is a study where they had the AI system take a case and then decide what the next best test is and look at the cost of that test versus how much diagnostic yield it had. And the overall findings, obviously Microsoft found its own system was the best. But if you look at this, you can see that every system is up and to the left of humans. So there is some excitement that maybe these could operationalize second opinions. Now, how does it work in the real world? This paper of mine is coming out. It just got delayed by a week, but it's coming out in Science in 3 weeks. So 2 weeks. Me and Rajman Rai basically recreated Ledley and Lusted's science paper, and then after taking that methodology, we ran a clinical trial in our emergency room of patients passing through the emergency room. Now, we did not serve up the second opinions to the doctors caring for the patients, but at 3 predefined points through their journey, we had 2 different AI systems and then 5 different board certified internists who were sitting in the emergency room give second opinions on what might be going on. And what we found is that, especially in points of low information density, the AI system, this is a reasoning model, O1 preview, the first reasoning model. This is how slow science is. Not that science moves slow, but technology just moves really fast. That the AI system outperformed the humans, especially in low information density. We now have randomized control evidence. This is a second opinion system at Penda Health in Nairobi, Kenya. Penda is a series of urgent care appointments. They got a grant from the Gates Foundation and later partnered with OpenAI to build basically a green light. So the medical officer, documents the visit with the patient in the room. A green light from the oversight system means there are no worries. I don't see any diagnostic discordance. A red light is you could potentially be missing something. The patient can't leave until you address this. And then a yellow light in the middle was obviously the least helpful, which is, consider looking at this. They randomized to 40,000 patients. They did actually have a composite outcome. It is understandably hard to get hard outcomes because this is an urgent care facility and separated from the downstream hospital outcomes. Also, incidence of a lot of things was relatively low. It's urgent care. But in their blinded review of the charts, there were significantly fewer diagnostic errors in those that received the system as adjudicated by blinded clinicians. So some RCT evidence. And I think the big picture is that, at least in the United States, I know that you guys had Babylon, which was it wasn't the best experience in the United Kingdom. As a new attending, I read all those studies with great interest. In the US, we've just decided to kind of let it rip. And these systems are widely deployed in the United States. K Health, which is deployed all over now. Actually, Dartmouth Hitchcock here in New Hampshire recently announced a huge partnership, and now you talk to K Health system before you come to the doctor. It just care navigates you. But this is an evaluation published in the Annals that showed that in this very specific narrow context, which is telehealth urgent care, the systems are capable of performing roughly human-like. K Health is really the only of these that has been very transparent about publishing, of the commercial ones, it's been really transparent about publishing its data. And I'm not aware of any, well, There are no pre-registered prospective trials. These are retrospective analysis. Okay, so that's the data around second opinions, and we can. And one second, I need to make sure that I'm not talking too much because my phone died. Okay, good. I'm gonna do this. I forgot to charge my phone last night. Classic move. So I want to talk very briefly about dyadic and triadic care. So again, this is going to be some of the US context here before I start to get into the performance paradox and the implications for patient safety. So, like I said, the US has taken I guess, a sandbox approach to regulatory issues. We have software as a medical device is our FDA sort of medical device guideline, and most of the uses that I've been talking about fall into a what was explicitly a gray area and now is explicitly allowed. So we have multiple patient-facing AI interventions that are being studied right now. I think the one that got the most press is the company Doctronic that is doing refills of medications in Utah. There's also refills of psychiatric medications. There are many AI doctor companies that have come up. AI doctor often is just an intake to a telehealth visit with a human provider. But the amount of Series A and Series B around these companies has been quite dramatic in the US with hundreds of millions of dollars. And then, of course, the big change in terms of patient-facing AI in the last couple of months has been that the hyperscalers themselves are getting involved. So ChatGPT for Health it basically creates not to get too technical, but they use Smart on Fire to pull patients' notes directly from the medical record into the ChatGPT chat interface. Microsoft and Anthropic now also do this. A lot of them are partnering with a company called HealthX that makes this relatively easy. I don't think any of these are in wide deployment yet. They're all being studied, but every single hyperscaler has gotten in, not every single, I don't think Google has launched anything as far as I know, and Meta has not. I don't know if they're a hyperscaler, but all of the big tech companies are getting involved in what I would call this sort of direct to consumer, direct to patient health coaching. They don't call it an AI doctor, but effectively pulling their health information into these chatbots. And now the US government, HHS, has actually shown keen interest in trying to encourage this sort of patient-facing AI that also brings doctors into the loop. Hyder Warwick is the program officer for the Advocate program. Advocate is a heart failure program, like patient-facing AI, sort of RPM management, with the idea that the AI talks not only to the patient and makes decisions, but also talks to the doctor. So there's a triadic care, which brings, I think, in my world, these are the two care models that we talk about. So dyadic care, which might be like ChatGPT for Health. Dyadic care is an interaction that cuts out the health system versus a triadic care model where there's patient-facing AI, but that AI also directly interfaces with either your doctor or your health system. Now, the reason this matters is that, so I study human computer interaction, right? I actually do the messy work of running trials and figuring out how a technology works in the real world, not necessarily, or even just the lab, and not necessarily an in silico evaluation. And one of the big takeaways, which shouldn't be a big takeaway if we listen to other fields, is that just giving people powerful automated systems doesn't always improve their performance, and it doesn't always improve their performance as much as if the system operated on its own. This matters a lot for second opinions. We know this a lot from the psychological literature. You can't just give people second opinions. When people ask for a second opinion, they're already aware of their own uncertainty, and the psychological research suggests that it's not a problem with doctors. Doctors are just human beings, but physicians or clinicians are very unaware of their own uncertainty or of the difficulty of the case. Second opinion programs from humans have been shockingly understudied. There is some data from patient self-referrals for second opinions that it improves care. There's not robust data from doctor-initiated second opinions. Now, in the past, this didn't matter. There's one of my favorite papers is by Tim de Dombal. Oh my goodness, which hospital was he in? Leeds. So Leeds in the UK, Tim de Dombal in the 1970s had AAP help. It's a Bayesian risk calculator, hugely influential in the pre-CT world for acute abdomen. He ran a multi-continent RCT, and one of his findings was if humans had just turned off their brain and listened to the AI system, they would have had even better performance. Mind you, they still had a really big performance increase using the system. And Dombal wrote a famous paper in 1978. This was after Star Wars came out, and he was a big nerd, as you can imagine that anyone in the 70s doing AI was. He was like, well, it doesn't really matter because at the end of the day, we need like a C3PO. We need a system that works with humans. And it's not like a patient is going to sit at a teletype machine and put in the data. Now, what's changed now, of course, is that LLMs are capable of interacting directly with patients. And this is my conflict of interest. This is my work with Google and DeepMind. We created a conversational, actually the first conversational diagnostic AI, AMI, Articulate Medical Intelligence Explorer, which again, standardized patients was able to make diagnoses reasonably well, management decisions, and then very cool was able to act in a supervisory loop, so able to take information and then hand off to a human who's overseeing it without doing anything unsafe within the confines of the study. And then we recently, like in January, we wrapped up, finished a phase 1 clinical trial of the system in my clinic. So this is a primary care clinic. You make a visit with your doctor. My research assistant calls you, consents you into the study. And if you agree to be in the study, you talk to the AI system. It has a clinical conversation with you. We had a safety supervisor live watching every single interaction with clearly defined safety interrupts. Then the AI system talks to your doctor. Then you go see your doctor. Often this would happen within 6 hours. So very like logistically tricky study to pull off. And what the results showed is not particularly controversial at this point, but these systems actually work reasonably well in the real world. They have similar diagnostic accuracy with just a text interface. They're able to make reasonable management suggestions. Patients didn't particularly trust the system, but their trust did increase as they used it. We've run a bunch of interesting subgroup analyses. This trial will be published in a major journal shortly, so I think that there'll be some interesting questions about how its performance varied by different types of diagnoses and whatnot will be out. But I'd say convincing proof of concept that this can work in a real clinical setting and not just a sort of wrapper for a telehealth setting. Okay, I could talk about a lot of the technical challenges, but I want to give time for questions. So if anyone, I'll stop sharing and take whatever questions you guys have. I'd say the big summary from this is that LLMs, with their ability to have a human-like ability of oversight, have ways of improving our traditional quality and safety systems that are fairly easily implemented, but also novel ways of interaction that are full of peril and promise. It actually could go horribly wrong if we don't get this right, and I am worried that there are companies that are pushing forward without appropriate evidence base. But in general, I'm cautiously optimistic about the ability of this technology to improve patient care. So I'll take any questions you guys have. And I can talk more if you want. Believe me, I'm great at talking.
Well, first of all, thank you so much, Adam, for presenting a lot of material in a short space of time. I know I'm not an expert in AI, so I was really trying to keep up there, but I think just about managed. But there are people in the room who are experts in AI and safety intelligence and so on. So, firstly, thank you for sharing that. And do we have any questions or comments?
Happy to nerd out about anything.
Paul.
Oh yeah, hi, nice to meet you. Thank you. Really interesting talk. I'm a psychiatrist, just about still practicing, but also professor of health data science at the University of York. So I'm going to resist the urge to nerd out, given that we might not take everybody with us. But I'm really, I suppose, interested in some of the transparency issues, things you talk about, and the
Yeah.
trials. And I guess one of our key funders, the UK NIHR, is often, is quite keen to support trials of this. And like you say, as you pointed out, does it actually translate into patient benefit, right? Because AUCs and stuff, they don't always translate.
AUCs are relatively
Yeah,
meaningless. The in silico.
yeah,
At the end of the day, how does it influence human beings?
exactly. So I guess what I'm interested in is there's a lot of retrospective studies. So do you think that the tech providers like, DeepMind, Google Health, whatever, Microsoft, are they willing to fund what we would see more as a gold standard kind of RCT type prospective studies that we, for example, if you had a new drug treatment or something, or whatever, because that effectively it's a health, it's clearly a health technology. So I suppose I'm concerned it's not being looked at in the same way, or not being appraised
Yeah.
in the same way
We're
traditionally
not
with
applying our
drug treatments.
heuristics that we use for other
Mm,
devices and drugs
mm,
to a new class of technology, right?
yeah.
I can speak for DeepMind. I mean, obviously, DeepMind funded what is effectively a phase one trial, and work continues with them. I will say, not all the companies feel that way, and a lot of the companies would argue. So, OpenAI would argue, we're not creating interventions. Now, ChatGPT for Health, you could say, is an intervention. We're creating a technological tool that other people should use and can, and so they're like, this is the equivalent, they would say, of us creating a like infrastructure, like and that someone else should test it. And I think that's what a lot of the companies would say. I don't know that's a very satisfying answer, because if you see what's happening, we're doing the EHR debacle all over again, right? We're rapidly deploying these tech, at least in the United States, into clinical workflows with very few prospective studies, certainly not to the level that we would treat a drug. I think your question is a good one. Who should fund it? I I mean, I would hope that the companies creating products should fund it, and I don't know why we're going with a different paradigm than we have for everything else.
Yeah, no, it's a difficult, and then one of them is about resources. So if we got a couple of £1 million from HR, we might have a 2 or 3 postdocs on it. But we know Google could put 6, 7 engineers and whether they've got almost limitless resources. So I guess that one of the issues, but also without obviously full cooperation, without full transparency, you can't really run a trial. So yeah, I guess it's a tricky one. I suppose the other issue is there is a question even with drug licensing, whether we need RCTs randomized, whether randomization is the best way, but there may be other causal inference methods we can bring to
Yeah,
bear.
there may be other, and you get to this is a problem that I struggle with a lot, especially having run a clinical trial in this, is that the underlying technology is changing rapidly, and from my perspective, the most interesting thing or most important thing to study is the workflow itself, not trying to isolate out the algorithm, meaning that we almost, by definition, you're not going to be able to study, like, is GPT 5.2 better than 5.4? You're not going to be able to run parallel RCTs, swapping out different work. It's not, so we need other mechanisms to talk about the strength of the algorithm itself. And then we have to be very careful that we're isolating either workflows or like a medical device. And then, at least in the US, I do a lot of work with the federal government, with ARPA and HHS, to try to figure out like, not even, so it should, like, my opinion is that it should be regulated, but like, how? And I think it's one thing to say there should be regulations, and then second, to figure out a regulatory mechanism, because our software as a medical device doesn't work. So anything that relies on classification and AUCs isn't going to work with a general purpose reasoning technology. So it is a, I think there are like real reasons that it's really tricky to figure this out beyond, like, no one wants to pay for it.
That's right. Well, thanks very much.
Thanks. We've got a few questions in the chat, Adam. So
Great questions.
if you don't mind if I put those to you. The first one is from Esther, and she says,
Yes,
thank
great
you,
question.
very interesting. Since human oversight is not scalable, how are you suggesting to scale that in the future? What would a safety system look like for you?
Oh, Esther, this is what I was going to, this, if I continue blabbering on, this is what I was going to talk about. A lot of my work rate, so this is the $1 million question. Human oversight is not scalable. A human in the loop system will not, human in the loop, you know that we talk about, we use autonomous weapons terms in medical AI, so I don't particularly like that we use the same words to define autonomous machines that kill people versus those that save people. A human in the loop system doesn't scale. Human attention doesn't scale. Humans are prone to automation bias. And even if we can get a system that works, it won't continue to work over time, because of these systems can de-skill people, especially if you're locked in it. So there's a need, to answer your question, to move into what is called a human on the loop oversight system. These largely do not exist yet in healthcare, largely because of the regulatory space, and also because of we call them edge cases in AI, but all patients are edge cases. So the idea here is that the system itself needs to have a appropriately calibrated level of confidence to hand off to a human in a way that doesn't overwhelm the human. So this AUCs do matter here, and in a way that is safe, that doesn't put people to undue harm. And I think that in order for us to figure this out, and this is where most of my research energy is spent these days, 50% of my research energy, we need to figure out how to move from, at least for certain tasks, from human in the loop to human on the loop systems. Otherwise, all of this is probably for naught and it won't scale.
Thank you. And Esther seems happy with that response. So that's great. Thanks, Adam. So a couple of questions around inequalities. So thanks, such an amazing talk. What's the potential here to increase or decrease health inequalities? Or I put the question in the chat, which is related. Do AI systems perform equally well for all patients?
No, I mean, I think everybody knows the answer to that is no. AI systems do not perform equally well for all patients. I can speak from my personal experience of running the trial, or we can talk more broadly. All of these systems are trained and fine-tuned on I shouldn't say they're trained, but fine-tuned on clinical data. Clinical data reflects the biases in society by what's collected and what is not collected, who's including it, who's not including it. These issues are generally mostly pertinent for sort of ML predictive or classification algorithms. But they also apply if you're reading, if you're making inferences, if you're bringing in sort of data representations, from an LLM that's making a decision, that's going to affect the performance of that also. So this is very well documented, and the same sort of issues that affect any sort of ML classification algorithm also affect LLMs. I think there's another issue that we don't talk about enough is that when it comes to patient-facing AI, there's another disparity that gets introduced, and I can tell you this was a huge problem in our trial, which is digital health literacy. As care gaps increase, and especially as these tools are very effective, at least within the studied population, who tends to be younger and more tech savvy, they're going to get rolled out in such a way that could leave behind people who don't have a high enough level of digital health literacy. None of this is new. We already see this. Like now, I can't call my doctor and get a person. I have to navigate through like an automated computer voice to get to my doctor, and that already is tough for like older patients or patients who have less health literacy. So my worry is that the direction we focus a lot, I think appropriately so, on sort of the societal biases that get baked in, but I don't think we've spent enough time thinking about digital health literacy and how that's going to negatively impact patients who can't or won't engage with the tools.
Yeah, so we recognize there are inequalities. What's happening to try and address these, if anything, Adam? Because I guess these systems are increasing, they are going to be used for the kinds of tasks that you describe. Are we willing to accept as a society that we will then bake in inequalities into our healthcare systems to a greater extent potentially than we already do?
So it's a fantastic question. I think that last one I can't answer that. I can answer the first one. What's happening? So there have been with reasoning models and the reasoning layer, there has been a lot of work to mitigate. LLMs when they first came out were capable of being quite biased, and there's a number of studies showing that they encode racial and gender biases. Largely because of a lot of those early studies and the labs paying attention, a lot of that has gotten a lot better in the setting of the reasoning layer, and there have been a lot of mitigations of that. Now, that doesn't solve the data problem. It doesn't solve the fact that data is not appropriately collected. Right now, whether this is good or bad news, I was going to talk about this also, language models actually aren't capable, and if anyone tells you this, they have a product to sell you. They're not capable of meaningfully understanding health data. Certainly not at any sort of scale that would be required for actual clinical care. So it gives us an opportunity because as we start to think about what data models we want to do to have models reason over health data, it gives us a chance to try to think of data models that can at least call out or mitigate inequities. A lot of this is theoretic at this point. If we're talking about like knowledge graph fragility, I don't know how much that correlates to missing data from like a minority patient who doesn't get as good care in the ICU, but it is a chance for us to care and think about it. So I guess the answer is I don't know, but as long as researchers, like I don't think the labs are going to be working on this, as long as researchers continue to care about this, and as long as there's funding to mitigate these problems, we've seen it not solved, but we've seen it mitigated in some of the reasoning layers. And I'm I'm not confident, but I think that it is possible that we can use proxies for fragility in like data representations to at least make the model aware that there might be bias baked in.
Thank you, Adam. So having a look at a few more questions in the chat. Gochi here says, thank you for your presentation, really interesting. You talk about patients' confidence in AI tools increasing in one of the studies that you referred to. How does clinician or healthcare professional confidence in these models compare?
We don't know. It's a fantastic question. There has not been a longitudinal study looking at how confidence over time for generative AI tech improves. I mean, what I loved about my clinical trial is that there's a lot of you guys have all heard like LLMs are more compassionate than doctors. One of the things I liked about my trials, and I think every doctor knows this, that that's not true. It's just an artifact of the evaluation mechanism. When you study it in the real world, no one finds them compassionate. One of my big questions is how does interacting with this tech affect physician confidence? Especially, I don't know about the UK, but every single one of my residents uses open evidence for their primary decision support, and I don't think anybody knows the answer to that right now.
Thank you, Adam. Next question. Where do you see the biggest patient safety risks emerging when it's used to optimize specifically hospital waiting times?
Is that what's happening in the UK? They're trying to optimize waiting times?
I don't know. Here, Maya, do you want to maybe elaborate on that question?
No, it was a general question because mostly in AI deployments, they focus on operational efficiencies. So I wanted to ask what other patient safety risks we need to consider.
And do you mean for language models in particular, or are you including all sorts of ML prediction algorithms?
No, uh, the first one.
Okay, yeah. So this is really interesting. It's interesting you mentioned that example of optimizing safety time. So LLMs are very steerable. What is steerable in this case means you can get them to do a lot of different things. Um, and because of that, they're very sensitive to their prompting and the situation that they are deployed in. To give an example, like everyone knows what a hallucination is. Yes, hallucination rates have dropped over time. I mean, there's higher levels of hallucination health data for a lot of reasons on how the data is structured. When an AI scribe hallucinates, it's very curious. It always hallucinates a higher billing code in the US context. Why? Because that system has been optimized either consciously or unconsciously to optimize billing. And my big worry for patient safety, I mean, I have lots of worries for patient safety. These things can be deployed in ways that could potentially be harmful, that could affect, I mean, one of the concerns is for language use. Like if we're replacing human interpreters with AI systems, that is not a good outcome. They probably should spend the money on interpreters. But from an algorithmic perspective, I worry that we pretend that these systems are sort of value neutral, like data from Star Trek. And instead, they're actually reflecting the purpose and values of who's paying for them, which is the health system. And in a way, we might come to rely on the diagnostic accuracy of our scribe when it's actually being optimized to generate billing codes to have higher reimbursement. So I think that's it, that the models themselves can reflect many different sets of values. And we, for some reason, treat that different. We think of AI as this sort of neutral arbiter when it is not, and is almost certainly reflecting what the purpose of the people who installed it.
Thank you, Adam. Some really interesting questions there about what AI does across different healthcare systems then, with different values and so on. That's fascinating. Jacob, I'm going to bring you in next and then come to a question by Sanchu in the chat.
Thanks, Rebecca, and thanks, Adam, for your really interesting talk. Very interesting work. So I'm attempting to use large language models to automatically analyze electronic patient records for evidence of unintended harm and staff adaptations, trying to improve patient
Awesome.
safety. I have a question about the trade-off between less powerful open source
Oh,
models
yeah.
and more powerful proprietary models, and kind of where you see the use cases going for both of those.
This is a great question. So are you working with Andy? Like, are you doing inpatient reviews, or are you mostly doing outpatient reviews?
Inpatient.
I waste I wasted like a year and a half of my life trying to do this work with what models are you using for the smaller open source models? Are you using Quen?
It's still in very early stages of development, so undecided. To be
All right.
honest, just
Then I can
generally.
tell you my experience if that'll be helpful. So I initially had the same idea as you when doing this work, which is that let's do smaller open source local models, especially if we can apply LoRa and do some degree of fine tuning. Um, Ultimately, what happened is that before reasoners came out, the like we were using Llama 3 370 billion at that time running locally on my cluster. So before it, and now I suppose you probably use Quen 3, which is two thumbs up to Quen. Um, it performed reasonably well on parity with the commercial models. Once reasoners came out, though, the performance I could not justify spending any more resources fine-tuning those small models. So our strategy has completely changed to using small. We still use the local small models, but we use them like in a graph rag technique to build a data structure and then feed that to the larger reasoner. So I think if I were you, I would look at using the intelligence of the larger models and then using the small models to try to populate some sort of data structure that do a shifting window technique and knowledge. Like nobody knows, but does that make sense?
It does, yeah. Thank you very much. Very helpful.
I'm highly caffeinated. I'm sorry. I realize I'm like fidgeting.
Maybe Jacob, you could catch up with Adam afterwards.
Yeah. I'll put my email in the chat if you want to shoot.
Yeah,
And
thank you.
I work with Andy Auerbach at UCSF as part of the Home Run Network. So we're doing a lot of this work in inpatient at scale.
Fantastic, Adam. Thank you so much. I think perhaps this may well be the last question. So if anybody else has a burning question they want to ask, either put your hand up or pop it in the chat. Are you doing any specific research, Adam, on the use in pre-hospital critical care settings with the emergency care clinicians or clinicians taking the first call to emergency services?
I am not. I am personally not. I know that my colleague Gabriel Bratt is doing this for traumas. And I will say K Health, that company, has gotten involved in this, and they have a system that can assist. But I personally am not. I think it's a very high. I like everyone knows what a Waymo is, self-driving cars. My personal opinion about like patient-facing AI is that we should take a Waymo model and target like the low risk things in the beginning and show that the low risk works with edge cases before moving on. And pre-hospital, a lot of this pre-hospital stuff, the edge cases are just so dangerous that I am very concerned because even if it works 95% of the time, the 5% of the time it doesn't work can be disastrous. So I'm not personally, but I know other people who are. Oh, Paul says Gemma 4. Yeah. This is great. I haven't used Gemma 4 yet. We did some work with Med Gemma. What's your experience with Gemma 4?
Gemma 4, I have to be honest, it's probably better than other local models I've tried, but to be honest, it's not as good as like Gemini 3.4 Pro or even Gemini Flash. I tried last week, I tried doing some screening, some abstracts and titles with it, which I'd done quite well on Chat GPT 4.0, on this sort of payment based thing, and it didn't work nearly as well. So I think there's no getting around it. Like you say, they're good, and like I say, the industry method apparently sometimes is to benchmark it across, pay for a load of tokens for a proprietary model, then try and get your local free model to get as near as it can using various tricks. So which makes sense in a way, and it could save a lot of money in long term.
Yeah, and it depends on what you use it for. Like we've used a Gemma 3, we use for like trial adjudication, right? I think for that very narrow task, you can do it. But if you try to use them like the larger models, you're going to be very disappointed.
Yeah, I think that's fair to say.
That's cool. I haven't used it yet. I'm excited. I bet my grad students installed it on my cluster because I don't really keep tabs on what they do.
I think people should be investing in better machines. I've got a 59 RTX. Sorry to nerd out everyone, but I've got an RTX 5090 GPU with 32 gigs, and it works great on that. But a lot of these models will not work very well or on poorer hardware.
No. I also have a GTX 5000 series on the computer I'm talking to you on now. At work, I have rent space on a cluster, so we have 8 A100s, which is great, right? I can run a quantized version of DeepSeek R1 on it, but I have to share it with other people.
Jacob, I don't know if you have the luxury of those high spec systems, so maybe we need to look into that for you. Thank you so much for your advice. I'm sure that was really useful for Jacob and an interesting discussion. I am going to finish it there, but with a huge thank you, Adam, for coming along and sharing your huge expertise, and for everybody for having the opportunity and engaging with the questions as well. So thank you so much. We will we have recorded this session, and it will be available on YQSR YouTube and on our SafetyNet website. So please, if you want to catch up on it afterwards or direct other people to it, please do direct them to that. Thanks so much.
And feel free to reach out, especially with technical questions. I love nerding out about.
Yeah, thanks so much, Adam. Sure, Jacob might.
Bye, guys.